name's Kate Comtois. I'm a psychologist in the Department of Psychiatry and Behavioral Sciences at the University of Washington. I'm also the director of the Center for Suicide Prevention and Recovery and the University of Washington Suicide Care Research Center. What I want to present today is recent research that we've conducted on the treatment preferences of individuals experiencing thoughts of suicide or engaging in suicidal behavior like suicide attempts. This has been an area of interest for me for a long time because of my work day to day clinically with people with suicidal experiences, as well as for the experiences of the people I conduct my research on, but I've never asked directly. And I think this is something that's really been long overdue, is asking people with lived experience directly about their treatment preferences. What help, in fact, do they want? Treatment for the care of individuals experiencing suicidal thoughts or behaviors, what I call suicide care, it often reflects clinicians' anxiety and concerns of liability, or their family's anxiety about them as a patient. And that often really, most of the treatment that we see in the community has a lot of these themes. Treatments that have been developed by clinicians who have spent a lot of time with people experiencing suicidality exist, and they are a small portion of the treatments that were developed. Many of the treatments have developed just organically in the field, not following any particular evidence base. And what we really know is that few interventions are co-designed with people who have lived experience of suicidality themselves. And it's really important to understand what this is about. I mean, it's really critical to understand that people with lived experience have thoughts and feelings and ideas about what they want. And I think that's only been evaluated with some simple treatment satisfaction surveys, et cetera. But that's often asking about a service that already exists. What we're studying in this study will help us provide more desired services, because we're going to ask about a wide range of services rather than just the services that they experienced. We would really like to help people avoid undesired options and to make sure that our research and development is invested in treatments that reflect the principles and the formats that people who are receiving suicide care prefer. So my goal today is to document a little bit about how people experiencing suicidal thoughts and behavior want to be helped. So I'm going to talk about two different studies that we've conducted recently. The first is an online survey. Participants were 1,000 approximately participants who were English-speaking adults living in the United States who have an experience of suicidality or have made a suicide attempt in the past. And these participants were recruited through an online research platform called Prolific, which is a platform that anybody can go on to. You start by kind of proving your identity to avoid fraudulent participation, and then you are offered a range of different surveys based on the characteristics that you described yourself with, and then you can choose to participate or not participate in any given survey. We used the survey that we developed in partnership with an advisory committee of people with lived experience of suicidality that we showed them through Prolific. I'm also going to report on a small qualitative follow-up that we're conducting in conjunction with an online study we have conducted on the use of Google, specifically search and YouTube. The participants in that study are English-speaking adults living in the United States who have experienced suicidality and or have made a suicide attempt in the past, and they use Google because that's part of our study. We recruited these folks online from the Mental Health America website. There was an overall sample of 484, and of this, we're going to talk about 30 participants who participated in qualitative interviews about their preferences for healthcare and some of the ethical issues in the use of social media and suicide prevention. So at the end of these slides are some slides about the study methods if you're interested in more detail about how we conducted the studies. So one of the things we did for our online survey or our first study was to look at what are the core values of care as defined by people with lived experience. So back in July of 2014, the group of suicide attempt survivors put together a report called The Way Forward, Pathways to Hope and Recovery and Wellness with Insights from People with Lived Experience. And they identified 8 core values that all healthcare should embody. So they emphasized fostering hope and helping people find meaning and purpose, preserving dignity, countering stigma, shame, and discrimination, respect and support for cultural, ethnic, and spiritual beliefs and traditions, connecting people to peer support, that would be other people with experience of suicidality who have been trained to provide recovery supports, promoting community connectedness, engaging in support and supporting the family and friends of individuals with suicidality, and promoting choice and collaboration in care, providing timely access to care and support. So we took these values and we asked our group of approximately 1,000 people who experience suicidality, and we asked them kind of how important are these values actually to you in terms of your care. So we gave them a scale to rate each of the values. We came up with some items that kind of reflected each of the values, and we asked them to rate them from very important up here at number 7, down to moderately important at 4, neither important nor unimportant, and 1, not at all important to them. The most strongly endorsed values were really around autonomy and respect and care. So the highest one was being treated with dignity and compassion, showing genuine concern and respect for my decisions, even when I don't agree with what is offered. Then there was a number that are in the kind of moderately important to slightly important category. These were characterized by access to care issues, providing access to care and support that fits my needs 24/7, offers timely access or referral elsewhere if care offered doesn't meet my needs, and provides you with healthcare choices that are easy to understand. The other common themes really have to do with those themes of giving hope and purpose in life and decreasing shame and stigma. Some of the other specifics about peer support or details about engaging family or friends or specific traditions were considered less important. So let's talk about some themes that we pulled out of our qualitative interviews with people with lived experience. These are our 30 people from the Google study who we asked about their treatment preferences. And autonomy was a really big theme. So I'm going to show you some kind of quotes that give you kind of a flavor for this. I feel autonomy is very important. So it's their choice, then it says it's your right to die. That's your choice. It's not my purview to interview if that's your choice. I don't like others telling me what to do and what not to do. I don't know. I guess it's really never okay to force anybody to do anything, because that's when it makes it worse, I guess, sometimes when you're being forced to do something you really don't want to do it. Having someone that isn't a cop doing a wellness check would be much better if they're trained specifically on that intervention so that you feel like you're talking to a normal person and not someone of authority. Now, I know that, you know that, but when you're at the lowest of lows mentally, you don't think that way. The police are here to take me to jail. The police are here to harm me. The police are going to kill me. All the stigmas again. And we don't take it all the way down to if this person feels safe, if they're going to talk to me safely. If I'm at home and I'm in my bed and I'm in my bedroom and I've got a TV on and this is where I feel the safest, okay? can I come in and talk to you in this space? But when you take somebody, you pull them out of your house, you take them down to the psychiatric floor at so and such hospital, you're taking them out of the control they have in their environment and putting them at, to me, a disadvantage. So these were common themes around care that reflect the themes we saw from the survey and the preferences of people with lived experience. In addition, there were also, again, themes around access to care. I think every medical plan in America should prioritize allowing people to have mental health therapy available 24/7, 365 at no cost to the customer or the person, period. It just kind of would have helped you call around if they find you a referral, get you set up. As I keep iterating again and again, it's like, oh, if you had a heart attack, you would not have the bandwidth to be able to do all that by yourself. So why do we make people with mental health feel like they need to carry all the weight on their shoulders to find aftercare? I believe that should be on the hospital. So going back to study one in our large survey, we asked people about their treatment preferences. Whoops. So we gave them a comprehensive list of conventional and some unconventional outpatient and crisis care options, as well as options to be rescued through like a visit to their home or wherever their location is because they were at risk. And we asked them again, we used a 7-point scale, and we asked for each of these types of services, 7 would be it must be offered, and 1 is, in this case, it should definitely not be offered. So 4 is really the midpoint, and everything above 4 is increasingly important, and everything below 4 should not occur. And we asked the questions differently for 3 different scenarios because we think those scenarios really may make a difference in responses, and we were curious what people would say. So we first asked people to look at the comprehensive list of services and say how important they were for people with mental health issues in general. We didn't want to confuse things that seemed specific for suicide crisis if it's just what people would have said anybody with mental health issues should get. We then asked people what should happen if someone was in a suicide crisis and intended to take their life within hours or the same day. So we were really trying to capture that real, genuine suicide crisis. And lastly, we asked people to look at the list in terms of people having thoughts of suicide or urges to kill themselves who are not in immediate crisis, or if it's days after they had made a suicide attempt. And we asked, I'm just going to kind of cluster them by the types of treatment. So these are some outpatient treatment options. So as you can see here, we have the blue, the green, and the red representing these 3 different scenarios. So the blue here is answers for questions around mental health generally. The green has to do with suicide crisis and an intent to die that day. And the kind of maroon color here for suicide, but not in a crisis. You'll also see that we asked separately for whether they had a history of ever having had treatment or help for suicidal thoughts or behaviors or not. We thought perhaps people with an experience of healthcare after a suicide crisis or during a suicide crisis might answer differently, but you'll see the results are a little bit different, maybe a little stronger feelings for people with a history of suicidality, but not dramatically different between those 2 groups. So again, 6 here is should be offered, 7 is must be offered. So anything in this range, we're talking about things that people feel very strongly should be offered. In this range, we're looking at things that would be okay, up to things that should be offered, things that make no difference, up to things that would be okay. And scores below 4 indicate that this should not be offered. Oops. So you can see here that primary care is in the okay to should be offered, somewhere in there. By contrast, it's clear that people do think an in-depth comprehensive mental health assessment should or must be offered. That psychiatric medications are in the okay to should be offered range. as is brief counseling, sort of that kind of immediate 1 to 3 weeks of counseling. A little bit higher for weekly counseling of a longer duration. Um, and you start to see a little bit of a breakout here when you get to intensive mental health programs, several sessions a week, kind of spiking up higher here for people in crisis or people who are suicidal. Counseling with a partner is a little bit lower, and a little bit more, especially for people with a history of having treatment, a little bit stronger actually for not being in crisis. Spiritual and pastoral visits were significantly lower, somewhere between uh, uh, neither positive or negative and okay. That's possibly representing kind of subgroups. Maybe some people thought it was much more important than others. So let's look at some less conventional support options. So in terms of peer support, we're seeing that that's a okay to should be offered kind of category, and a little bit more so for people who are suicidal than mental health in general. That lower, again, similar to the spiritual care, is traditional or cultural activities. Although in this case, we could compare our small sample of those who are American Indian or Alaska Native to our full sample, and you can see that there were differences with it, particularly with the group who've had mental health care before, that they are more likely to think that it's in the kind of okay area. We were sort of surprised to see how popular websites with helpful information were, particularly for people who are suicidal but not in crisis right now. And you see a similar pattern for mental health apps. I suspect that apps are slightly lower because they often have demands within like smartphones and data, etc., that are a little bit harder to use if you have limited resources. In terms of crisis, the crisis line was quite popular, so that's really good, even though sometimes those of us who are working with suicidal folks see people kind of flinch away from the crisis line. If you look at folks in general, both who've experienced suicide treatment and not, they do highly value it. The emergency department, as you would expect, you're starting to see that sort of spike in the center for people who are at imminent risk, and it falling away as something acceptable for anybody else. And I think this is important, seeing that we're not even at the okay level here for those who are suicidal but not at imminent risk. Probably makes sense. Inpatient psychiatric care is similar, but a little lower than crisis respite care. So this is really great support for a lot of work that's happening in the community right now to build crisis respite options that are outside of a hospital, but are a safe place to stay for a day or so. That's certainly more popular, and definitely a little bit higher for even people with mental health and suicidality that's not at imminent risk among people who've had treatment experiences. Comparably for residential care, which would be a place where you'd stay for more than a week. And then let's look at some rescue options. So we asked about a number of different ways that somebody could come to your home to try to help you. And the first folks are paramedics or other emergency healthcare folks coming to your home or location to try to provide a rescue for you when you're at imminent risk. Obviously higher for imminent risk than anybody else, getting pretty low down here in terms of anybody else, but definitely in the okay to should. I was actually a little surprised that it wasn't higher than should, definitely not at most must be offered. Other folks like firefighters or crisis workers coming to your home, pretty comparable. Starts to go down when we talk about police visits from like community police folks or mental health police folks. People are much less happy about them coming, and we've really crossed that line here in terms of people wanting someone to come to their home unless it not being okay unless they are at imminent risk. And even at imminent risk, we've fallen below the 4 here for standard police. So there really is a strong desire not to have the standard police come and do a wellness visit on somebody who's suicidal in their home. So I think that just to kind of flesh that last one out, I thought it might be useful to look at some quotes that people gave us about their experience with police and EMTs and other rescues. So for instance, I received professional support from the police as the neighbors informed them about my situation. So that was a positive experience that they felt that it was professional. My mom called the police to have them check on me, and the officer that came to my house was extremely helpful. He was kind, and because of the way he talked to me, I took his advice and let him drive me to the ER, and from there I went to an inpatient psychiatric unit for a week. The EMTs that attempted to help me seemed caring and supportive. We're seeing that constant theme. The suicidal hotline volunteer was helpful, although I was concerned about being locked away. However, people have had, as you might expect, some very negative experiences with the police and EMTs. I think being transported to the inpatient psych ward with police escort was very, very not helpful. Being body slammed by cops and dragged to an emergency room, the police have always been there to make the situation worse for me. So what can we make in conclusion? These are 2 of the fewest, and this is the largest study that we're aware of healthcare preferences among people living with lived experience of suicidality. We see that the most important values that were called out really have to do with feeling cared about and autonomy, right? Being treated with dignity and compassion, showing the providers showing genuine concern and respect for their decisions, even when the patient doesn't agree with what's offered. And this stood apart from a lot of specifics about how care was provided. It really was so much about the clinical dynamic between the patient and whoever was helping. And this is really in contrast to standard approaches to folks who are suicidal, because that really prioritizes their safety over their autonomy and choice. And of course that, there are many kind of legal and ethical issues that are part of how clinicians end up making those choices. But I think it's something that we really need to put front and center and really start to grapple with the fact that there really is this discontinuity between what's important to the suicidal person in their suicidal crisis and what the system feels it needs to do. And lastly, I do think that access to care was also a pretty constant theme, and we see that, of course, across our healthcare system and with mental health and substance abuse care in particular. In terms of the services that people preferred, psychotherapy and counseling were highly valued. Websites and mental health apps were particularly recommended. There's a lot coming out right now, and so that really strengthens the value of evaluating the content of these materials, the legitimacy of these materials, and potentially doing more clinical trials to evaluate which have the best evidence in reducing suicidality. Crisis lines like 988 were highly valued, as were the crisis respite options, which again, this is excellent because that's really where the national priorities for suicide prevention are going. So it's good to know that people are really in agreement with that. Rescue operation interventions were recommended only for suicide care in a crisis, which makes sense. But it should be noted that even in a suicide crisis, participants believed that the standard police should not be involved in a rescue at their home. So I would like to thank you for your attention and interest in what people experiencing suicidality have to say. Feel free to contact us for any questions or further information at the Center for Suicide Prevention and Recovery. You can see our website and our email here. And what will follow are the slides covering the specific methodology we used in both of our studies. Thank you so very much.